Hello and welcome to the Medical Mind. My name is Upon Vincent Apraku, and in today's video, we are going to be talking about medical history taking, one of the essential skills that is required of any healthcare practitioner. Now, I know it may sometimes feel overwhelming with a lot of questions that you're supposed to ask, but don't worry. Today, I'm going to share with you a simple and effective approach that is going to make history taking easy and concise, but still getting the crucial information you need. Now, why is medical history taking so important? It is the foundation for a correct clinical diagnosis. Asking the important questions can help you uncover hidden clues about a patient's health, guide your decision making, and ultimately improve the care you provide. So grab your notebook and let's get started. Before we start everything, I want to start with a disclaimer that I am not a medical doctor. I'm just a medical student. This video is a compilation of the things I've learned and what I've been taught, which I seem essential or important for medical students. This is not the only standard way of taking history. Now that the disclaimer is out of the way, let's get right into it. We are going to use the Cambridge framework, and it involves the date and time of commencement of the history, introduction and rapport, the demographics of the patient, the presenting complaint, the history of the presenting complaint, the indirect questioning, the systemic enquiries, the past medical history, the food and drug history, the family history, and the social history. Before you take any history, you have to remember the context in which you find yourself, because taking history in the emergency room may be different from the history you take in the medical ward or the surgical ward. For the date and time, all you have to do is to just put the date and time of the commencement of the history. For the introduction and rapport, this is to create a cool environment that will foster the history taking and asking of simple questions. What I usually say to the patient is, "Hi, my name is Vincent. I've been asked by my supervisors or my superiors to take your history. It involves me asking you certain questions. At any point in time, if you feel uncomfortable, you can tell me and I will stop at the process. You have your consent to continue." They will probably say yes, then you continue. If they say no, the history ends there. For the demographics, what I usually use is the NASMORA. So the NASMORA, you are confirming the patient's name, the patient's age, the patient's sex, the marital status, the occupation, the religion, and address. And sometimes you add the contact number of the patient and the address. So now you will move on to the presenting complaint. So for the presenting complaint, you ask simple and open-minded questions such as, "What made you come here today?" Or "Why are you here today?" And you allow the patient to talk without interrupting. So for the history of presenting complaint, you are trying to understand how the thing happens and how it is progressing. If patient is presenting with pain, use the mnemonics, Socrates, which is the site, the onset, the character, the radiating factors, the associated symptoms, the timing, the exacerbating factors, and the severity. That has to do with how bad the pain is. So if it's a non-pain presenting complaint, I usually use the mnemonics, adopts, the associated symptoms, the duration, the onset, the progression, timing, and the severity. So the timing has to do with what time is it usually severe or what time does it usually come. So when patient is presenting with vomiting, you will classify the vomitus using the BCCCOV. The BCCOV stands for, is it blood stain, the content of the vomit, the color of the vomit, the consistency of the vomit, odor, and the volume of the vomit. So what happened before, during, and after for episodes of collapse or self-harm is usually important to ask. For the indirect questioning, it's usually done to eliminate your differentials. So this is usually dependent on the presenting complaint. So usually when the patient is presenting with any symptom that is of the gastrointestinal tract or of the cardiovascular system, you ask questions of the systemic enquiries relating to that particular system. There are certain general questions you ask for any patient, and that the mnemonic is flown. That's for fever, lethargy, anorexia, weight loss, and nausea. So after the indirect question, it's usually advisable to ask the patient a question like, "Anything else?" Okay, for you to capture all the things that you are not able to ask, and for also to ensure the patient that you are really listening to him and you care about the condition. Now you move on to the systemic enquiries. And for the systemic enquiries, you usually group it into the 6 main systems. That's the genitourinary system, the gastrointestinal system, the respiratory system, the central nervous system, the musculoskeletal system, and the respiratory system. For the gastrointestinal tract system, you will use the mnemonics digest, which is D for dysphagia, I for indigestion, G for gas, that is bloating, E for emesis, S for stool changes, and T for taste changes. So for the cardiovascular system, the mnemonics we use is painful, that is P for pain on the chest, A for activity or exercise, I for intermittent claudications, N for nighttime symptoms like paroxysmal nocturnal dyspnea, F for fatigue, U for unstable angina, and L for leg swelling or edema. So for the respiratory system, the mnemonics I use is chest. That is C for cough or chest pain, H for hemoptysis, E for exertional dyspnea, S for sputum production, and T for tightness of chest. For the central nervous system, the mnemonics I use is neuros, N for numbness, E for eyesight changes, U for unsteadiness or balance, R for any radiating pain, O for orientation, and X for speech difficulties. So for the genitourinary system, I usually use the mnemonics urinary, U for urine output, R for renal colic or flank pain, I for incontinence, N for nocturia, A for any abnormality in the genitourinary system like hematuria, discharges, sores, and ulcers, R for urine retention, and Y for yielding, that is straining and hesitance. So for the musculoskeletal system, the mnemonics I use is sprain, S for joint stiffness, P for pain at the joints, R for any limited range of motion, A for any associated symptoms, I for any injury at the muscle or joint, and N for any noise when moving. Now you move on to the patient's past medical and surgical history. So you are going to ask about any previous admission or current situation or any previous surgical condition. And also you ask about any chronic disease. The mnemonic we use is stress. T for tuberculosis, H for hypertension, R for rheumatoid arthritis, E for epilepsy, A for asthma, D for diabetes mellitus, and S for sickle cell. The trick here is whenever you ask this question, then you go on and ask, is any family member having these chronic conditions? Just to cut you asking the same questions in the family history. Then you move on to the drug and food history. Here you will use the mnemonics medicals. M for any medication, E for the effects of the medication, D for the dose of the medication, I for any drug-to-drug interaction, C for any changes in the medication, AL for allergies, and S for any supplements the person is taking. Now you have to remember that whatever drug the person is taking, you have to require about the frequency, the dose, and the route of drug administration. So now you move on to the social and occupational history. And the mnemonics here is socials. So X for support system, whether the person is insured on the insurance scheme or the person is paying for everything himself or is being funded by family. So O for the occupation of the person. So C for cultural beliefs, and you will be surprised how cultural beliefs can really help you in treating certain conditions. I for the interest of the person, A for activity such as alcohol and smoking habits, L for living situation at the home or place he works, and S for suicidal thoughts. For elderly patients, it is advisable to ask about the activity of daily living, that is the ADLs, whether the person is able to walk by himself or he requires the help of people to do so, or do certain minor activities by himself, or he requires the help of other people. Thank you for watching this video. Don't forget to click on this video right here. See you in that video. Bye bye.